Good evening, everybody. Thank you so much for joining me tonight. I'm Dr. Howard Elkin, the medical advocate. And tonight we are going to focus on hypertension or high blood pressure. Now, you may ask yourself, why do we have to focus on this every single year? And I'll tell you why. It's because of the prevalence of the disorder. It's so common. And I just think it merits it. The reason why it's here for we celebrate this every May, it's a great time to think about what do we know, what do we don't know, and most important, what's new. And that's what we're going to discuss this evening. So again, the reason why it's so important is because of the prevalence of the disease. And how prevalent is it? Well, let's just say that 47% of the adult American population is hypertensive. That's almost half. That's 160 million people. Now, when I wrote my book, which, as you know, has been out for a few months now, for both sides of the table, when doctor becomes patient, but it's more about become your own medical advocate. When I wrote that book and I did my research, I think there were like 75 million people with hypertension. In the last 10 years, that's grown to like over 100,000, 100 million people. So the numbers keep increasing. And if you don't, and most people, this is an important thing to remember, most people are clueless. They don't even know they have it. And the majority of people that have it are inadequately treated. And that's really important to me, is to make sure blood pressure is controlled. It's that important. It's the number one risk factor for heart disease. And also in my book, I talk about that. If you look at my section on risk factors, the first thing I mentioned is blood pressure. It's so important that it be maintained, regardless of how you do it. Now, if you want more useful information, 7 out of 10 people, out of 7 out of 10 that present with their first heart attack are hypertensive. Now, fortunately, I'm a cardiac patient, but I wasn't one of them. I've been blessed with good blood pressure. But 7 out of 10, and you know, if there's something else, 8 out of 10 people with a stroke are hypertensive. So, major risk factor, folks, for these particular disorders. So, it may be quiet, but it's very pervasive, and you see it everywhere. And that's why we talk about it tonight. Now, sometimes I have to break my own rules. So if you would listen to my video on Heart Month back in February, and also read my blog, you know that I'm more about, number one, know your risk. Your risk is more important than the actual numbers. But when it comes to blood pressure, folks, your numbers are really important. So I break my own rules for that. And there's two aspects here: knowledge and action. Know your numbers. And what are the numbers? Well, when I was a student, because years ago, 140 over 90 was considered borderline, and we didn't do anything about it. Now that's clearly elevated. In fact, anything over 130 over 80 is considered elevated. So let's say it's 131 over 81, you're hypertensive. There's no two ways about it. And it's not just like some white green plot to make you go out and get more medications. We have documentation and studies that prove that the lower your blood pressure, the less likely you are to have stroke and heart attack and kidney failure and other problems like that. So it behooves all of us to maintain a normal blood pressure throughout our lives. I'm always asked this question: well, what's the optimal blood pressure? If you're 20 or 30 or 40 or 60 or 80 or 100 or 100 plus, my answer is always the same: 120 over 70. That's the ideal blood pressure. And does that mean I try to get that in every patient? The answer is absolutely no. If I did that, I'd have patients on 2 and 3 medications easily, and then have to come see me every 3 or 4 weeks in the office. It's just not logistically possible. But that is the aim. And we do know that people with that blood pressure, 120 over 70, do best for the long term. Some other surprising facts about blood pressure is that it can be linked to dementia, and that's really important. Now, we know that high blood pressure is linked to heart disease, meaning heart attacks, strokes, and heart failure, and also kidney failure, and also cognitive impairment and dementia. So there have been studies that, at least for several years now, that have linked elevated blood pressure in middle-aged folks and dementia as they get older, or cognitive impairment. So that alone makes me shriek and say, no, we got to control blood pressure, because who in the heck wants to have a good heart with a bad brain, right? So that's very important. That link is well established now. And as the population gets older, we're seeing more and more dementia. Now, young people can have blood pressure too. Now, get this. I saw a patient a week and a half ago, a 21-year-old. Okay. Now his blood pressure he has been seen at UCI, University of California at Irvine. It's a university hospital. What they do? This guy's morbidly obese. He's about close to 300 pounds, maybe 5'8", 5'9", about something like that. And what do? They put him on not one, two blood pressure medications, and his blood pressure is adequately controlled. But did they talk to him about metabolic health? Did they put him on a program, an exercise program, a nutrition program? No. All they did was give him two medications to support his blood pressure. So we see it in young people as well. And as I alluded to earlier, blood pressure elevations or hypertension, you don't have to have any symptoms at all. It's nice when patients have headaches, they feel flushed, or they feel dizzy. I mean, we don't like those symptoms, but at least it alerts me, the doctor, and the patient that something's wrong. But the majority of patients that I see over all the years that I practice, they have basically are asymptomatic. They have no symptoms at all. So it is a silent killer, and most people that have it don't know it, and they aren't getting checked out. They don't know their numbers, and they're not going to treat it. The average doctor isn't like me. They're not going to be scrupulous about blood pressure control. It's okay. Well, 140 overnight, it's okay. It's not too bad. It is bad, and we have to treat it. So what is blood pressure? There's two numbers, the top number, which is systolic, and the bottom number, which is the diastolic. So the systolic is with each beat, your heart has to squeeze to get the blood out of the heart into the aorta, into the rest of your body. That's the systolic blood pressure. Then the second is the diastolic, when the heart actually relaxes in between beats. Now, so what do we do? That other question is, do we worry about the top number, the systolic, or just the bottom number? Again, when I was a student and an intern, we only worried about the diastolic or the bottom number. 140, 150, we didn't treat it. We did not treat it. How little we knew. But when I was a fellow in the early 80s at Northwestern, we learned that there was a special landmark study called the SHEP study. SHEP, systolic hypertension in the elderly population. I think elderly was considered over age 60. Anyway, then we learned. And then there, if you follow these patients long term, those with systolic blood pressure have as many strokes and as many heart attacks as those with diastolic hypertension. So since the 80s, we really treat both. They're both equally important. Yet I still get this question: do I have to worry about my systolic? Yeah, you do have to worry. Okay, so what about the epidemiology or the prevalence of the disease? As I said before, 47% of adults have hypertension. That's half the population, or close to half of it. And it's more with men than women. I think with men, it's 51%, and women, 39.7%. So it's a little bit higher in men, but it's an equal opportunity killer, just like heart disease is. And here's my selling point for this particular talk. If one of your parents has a history of hypertension, you have a 25% chance of contracting the disorder yourself. If both of your parents, you have a 50% chance. And I don't mean to say that you're screwed, but that's a big thing. And we're going to get into genetics in a few minutes, but that's something hard to take. So you can't buy your parents, but these are things you have to consider. Genetic predisposition is very, very significant. Now, is it just happen in the elderly population? The answer is no. Like I said, I just saw this young kid, a week and a half ago, and it was history of hypertension. He was morbidly obese. But if you look at the age breakdown, I have to read this because I'm very bad at numbers. From ages 18 to 39, I consider that as pretty young. The prevalence is 22.4%. That's almost a quarter. Okay, that's a lot. From ages 40 to 59, 54.5%. So that's over 50% of the population, okay? And then ages 60 and up, 74.5 or 75% of the population is hypertensive. So it's there from teenage to all the way through being in the elder population. And of course, it gets worse as we get older. It's higher in blacks than it is in whites. In blacks, it's 57% prevalence, and in white Caucasians, 43.7. Now, what do we know about blood pressure? What do we know now? It is kind of age related. We see it in all ages, but as you get older, we see it more commonly. There's a diurnal pattern. So normally your blood pressure is going to be higher in the morning when you awaken, because that's like when your stress hormones are raging, they're active. We're talking epinephrine, norepinephrine, and cortisol. So that's why if you take your blood pressure in the morning, it's going to be higher. As the day goes on, the number should go down. Okay. And also if you take it after exercise, but within 20 minutes of exercise, you'll see that blood pressure is lower. So that's the diurnal pattern that we commonly see. It's not that way in everybody. There can be a paradoxical response. Some of my patients have elevated blood pressure at night. I can't explain why. It's not the usual pattern, but it does exist. So when I have my patients monitor the blood pressure at home, I have them do AM, I have them do PM, and I have them doing post-exercise. They can see exactly what's happening. Okay, exercise, which we'll talk about in a minute, has an active role in decreasing blood pressure. And 92% of people with hypertension, it's basically, we call it essential hypertension. That term's been around since when I was a student in the late 70s, meaning we don't really know what causes it. We do know these patterns that I've described, but there's no anatomical reason or explanation for it. So, in 92%, it can be, there are some rare causes that we occasionally look for, but it isn't worth doing exhaustive workups in your average person unless it's uncontrolled hypertension, because most of the times we'll never find an answer. It's just essential hypertension, meaning we don't know why it's there. And there is no cure. Okay, it's not going to go away, but it can be easily managed with lifestyle, and sometimes we have to use supplements and even medications as necessary, but it should and can be managed. So what's new? And that's really what I talk about. I'm very excited about this new health analytical tool that we can use for detection of genetic polymorphisms, or SNPs, which is single polymorphism, nucleotide polymorphism. It's a big term we use in genetics. So we can detect these abnormal genes that are associated with cardiovascular disease. So it's not just about hypertension. Hypertension is a biggie, but we can also detect genes for heart failure, diabetes, insulin resistance or metabolic syndrome, atrial fibrillation, stroke, and dyslipidemia or abnormal cholesterol and lipids. So it's a really exciting field. So the lab that I am talking about, it's, first of all, the name of the test, which I will be using very shortly in my office, is Cardia X, Cardiax. The name of the lab is Vibrant Labs America. It's a not new, but it's a lab based out of San Francisco, and they measure 25 genes related to cardiovascular disease and hypertension, 25, which is really, really exciting. So why do we need more testing? Well, because as medical advocates like you and me, we want to be able to have an impact on the prevalence of this disease with early risk detection with a focus on prevention. I'm all about practicing prevention. So as we know more about individual patients and their risk, we hopefully will be able to have less of disease as we go older. Now, genetic testing is not new. Those of you that work with me or have worked with me know that or have seen me on social media or on my blogs, know for that I use specialized lipid testing such as Cleveland Heart Lab and Boston Heart Diagnostics. Those are two excellent specialty labs that I use, both of them, and they do have some genetic testing. There's about 6 or 7 different genes that I commonly test for that I have found very useful for my patients. We don't necessarily can change the genetic. We can't change the genetics. I do it one time a test, but we can can focus more on the expression, which I'll get to in a minute. So, but this new testing, Cardia X by Vibrant America, is the largest collection of genetic mutations that I've come to that can lead to risks. So it's really a new thing. So you're hearing cutting edge information tonight. So who should be tested? Obviously, we're not going to test everybody. And by the way, it's not a cheap test. And so far, it is not covered by insurance. You got to remember, folks, functional medicine tests really aren't covered by Medicare or insurance because they don't really care about keeping you healthy. They really focus on disease. Whereas as a functional medicine practitioner with integrative cardiology, I'm trying to get you to not get to that position, to keep you healthy. So these tests are very useful, even though they aren't covered by insurance. And we're seeing more and more testing, specialized testing, that is not covered by insurance. So don't expect your insurance going to cover all this stuff. If health is really your main priority, and it certainly should be, then I would focus on that and forget Starbucks and all the other stuff that we're spending our money on, because it's really important. But who should be tested? Not everybody with blood pressure. That's ridiculous. Like I said, half the population has it, or nearly half. If there's a family history and you fall in that category, one or both parents, you might want to see whether you have the genetic mutations to develop hypertension as you age. Uncontrolled hypertension. Sometimes if I can't get it controlled over 2 medicines, 3 at the very most, then I need more information. Something's wrong. I will then maybe look for a secondary cause, or this would be a great opportunity to do advanced testing. Then also a history of cardiac events. I'm a cardiac patient. I talked about it in my book. And unfortunately, I'm blessed with really good blood pressure. I always have. But the average person isn't. The average person has blood pressure who's a cardiac patient. So that would be useful. Metabolic syndrome. And those of you that know me know that I really focus a lot on this and for good reason. 42% of the population in this country is obese. Over 70% is overweight. And these are the people that often have high blood pressure. And also elevated inflammatory markers. Another thing that I'm pretty well known for, I check inflammation in all my patients because it's such an important harbinger of disease, all the diseases of aging, not just heart disease, but heart disease, cancer, autoimmune disorders, and Alzheimer's have one thing in common, folks. It's inflammation. So I check inflammatory markers. And if they're elevated, another good reason to do this type of testing. So there's numerous genes for hypertension that have recently been discovered that are that we would be studying in this particular test. It kind of adds a whole new meaning to the concept of family history. Oh, family history. Well, it's in my genes. Well, is it really in your genes? And now we can actually detect this. And the aim of this testing to me, which is so exciting, is that it will help your doctor measure the genes that can lead to hypertension. As a result, give you a direct, personalized, and precision treatment program, because that's really what functional medicine should be about. Individualized program for you, not for the other person. So it's precision medicine at its best, and I'm so excited to announce this to you. It's like getting rid of the trial and error. Back to my book, which I hope all of you will get. And by the way, the website that I have this is beyourownmedicaladvocate.com. Again, beyourownmedicaladvocate.com. And it's a good website. It's just devoted to my book. You can go right to my Amazon page and purchase the book for, I think that the Kindle is $9.95 and the paperback is $18.95. And please leave me a review at the end. But anyway, most important, when I talk about hypertension, I talk about it's basically trial and error, which it has been all the years. It's not a cookbook. Medicine today wants to kind of make things cookbook like. Everybody should get this drug. Everybody should. It isn't that way. That's why I don't work in a large hospital or work for a large medical group, because I've always worked on customized programs for my individual patients. But this will take the guesswork out of it, because it has been a trial and error. Oh, this didn't work, so I'll try that. So to have this information will be incredibly worthwhile. So the end result, when you get out of the trial and error, is that your blood pressure is better controlled sooner, better, and with less drugs, and hopefully with better outcomes. So I think we'll be able to discover what genes are the culprit. Exciting, right? But it's not just about your genes. Okay, those of you that know me know that I also talk about epigenetics, or how these genes are expressed, which is really, really vitally important. Because if you look at the totality of things, about 30% of our clinical outcome is based on genetics, but 70% is based on lifestyle. And that's what we talk about when we talk about epigenetics. So it's how these genes express themselves. Yeah, we'll find out from this testing what your genes are like, but how do we switch them on and switch them off? We don't want the bad genes to be switched on. We like them to be switched off. And how do we do that? And that's by gene expression and through epigenetics. Well, we're going to talk about one thing, and that's inflammation. You guys know about how important I emphasize inflammation, because inflammation is going to turn those bad genes on. Okay, and that's why it's so important to monitor your inflammation. I don't know. I think most doctors don't really order inflammatory markers. I do. It's very important that I work on this, and I have a nutritionist, and we work very hard on people's gut and the oral cavity and the gut, but that's your major sources of hidden inflammation. You got to know this stuff. So most of these active genes that are turned on, that are associated with hypertension and heart disease and heart failure, or through inflammation, number one. Number two is oxidative stress, which is like free radicals, which increases as we age for everybody. And then immune vascular dysfunction. And of course, those of you that know me know that I do additional tests. It used to be called the Pulse test, PULS. Now it's changed to Smart Vascular DX by a lab called Morningstar Labs in Irvine, California. And we're looking at endothelial health. And the endothelium is 1 cell thick, and it lines all 60,000 vessels. We have 60,000 miles of vessels within our body. and the endothelium is one cell thick that lines every one of them. So when that becomes dysfunctional through age, smoking, pollution, poor sleep, stress, blah, 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 then that's another way to get these genes switched on. We want it to be switched off. So switching off the bad genes, how do we do it? Well, diet is one way. It's been shown so far that the Mediterranean diet can be very helpful. We still don't know all the answers, but that's the one diet that has clearly been shown in the prevalence study back in 2013. It was a large Spanish study that the Mediterranean diet, and we've talked about that before, and we'll talk about it again another point, another program. Actually, it's the only diet that's been shown to actually prevent heart disease. Certain electrolytes, we'll be able to see, well, potassium, magnesium, sodium, calcium, and then various supplements and even drugs. It'll be really nice to know, well, beta blockers really, for this genotype, not a good thing. Maybe choose a calcium blocker. Maybe choose an angiotensin receptor blocker, an ARB. So again, it takes the guesswork out of medication profiling when you need to use medications. So let's talk. So it's very exciting to me. I get very passionate about it. And I will devote an entire program to this at a future date once I'm actually using it. It's relatively brand new. If you go to Vibrant America, you'll see there's one page on Cardia X. It tells you nothing. But I am rapidly getting information on this, and I hope to have it available in my office in the next several weeks. So stay tuned. So treatment. I always look at non-pharmacologic treatment first because it's lifestyle, folks. What can you do to control your blood pressure without going to drugs? Number one is hydration. Do you know that 75% of adults in this country are dehydrated, chronically dehydrated? That's not only good for your blood pressure, it's not good for your mentation and your fatigue and weight gain. All these things do better once you're hydrated. It's number one in my book is hydration. I start every day, folks, with a glass of water and freshly squeezed lemon juice from an organic lemon every day without fail. I start my day because you're dehydrated being asleep for so long, right? Weight loss. It's no question. If you can lose 10% of your current body weight, so if you're 200 pounds, and if you're fat, I mean, I'm 200 pounds and I'm really not fat, but if you lose 20% of your current mass, 10%, you'll see a decrease in your blood pressure. It happens almost whenever my patients lose weight, the blood pressure comes down most of the time. Smoking cessation is a must. Smoking will clearly increase your blood pressure. Alcohol, another thing. Those things are just bad. And treatment of sleep apnea. Now, I had a patient several years ago, and I could not get his blood pressure controlled. I tried all kinds of stuff. And I was a young cardiologist at the time. And I finally figured out he had sleep apnea. Once we had him on a CPAP mask, blood pressure came under control. Exercise. I've talked about exercise before. It relaxes the blood vessels and allows them so that the heart has to work less hard to pump blood through them. And a number of studies have shown the beneficial effects of exercise on hypertension in both systolic and diastolic. And most studies have shown that you can decrease it by 5 to 10 millimeters of mercury on both systolic and diastolic. So it's really something that should be done. You guys know how much I praise exercise or talk about it. And resistance training. Now, we've known since 2010, that's a long time ago, in a journal of the strength and conditioning, that weight training, resistance training, in itself has a longer lasting effect on blood pressure control than aerobic. Can you believe that? And why doesn't people know this stuff? It's not praised because strength training, the benefits of it, which I talked about several weeks ago on my program on muscle, it just hasn't been well appreciated by the medical profession. It has by me, but it hasn't been the medical profession. So that's really important. Then there's also a biofeedback, which I think is really interesting. So biofeedback is kind of using a greater awareness of your body's functions, physiologic functions, to control your blood pressure. Getting your heart rate under control, your temperature, talk to yourself. I did this when I was a runner, way before I became a bodybuilder, and I was wearing a heart rate monitor. I remember this vividly, and I would go up this big hill. I'd say, okay, I'm going to keep my heart rate under 130 or 140. I would not allow myself to go above that rate. And how'd I do it? I slowed down, obviously. I slowed my pace down, or my stride was less, but my mind told my body, we're not going to get a blood pressure higher than this. And it worked almost every time that I did it. So that's biofeedback. And there's one program, one particular program that I like, that I've mentioned before. It's called Respirate. Now, it's RESP, little e, RATE. And you can get it on Amazon. Look it up. It's the only non-FDA approved, non-pharmacologic tool for blood pressure control. There's no drugs. And it's been endorsed by the American Heart Association, which, as you know, is a very conservative organization. And I think it's been at least 16 clinical trials using this. It's very interesting. So how they do it, there's a belt that you wear, I'll show you, like in the upper abdomen, and you have a monitor, like a computer, and you hear these musical tones. And the tones, your brain wave hits to listen to these tones, and it actually says, breathe in, hold, breathe out. So it's a form of meditation. Now, I personally don't need that, not just because I don't have hypertension, but I do meditation practice every morning, every single morning. And I actually teach patients how to breathe. You'd be surprised, and people do not take the time to breathe. And so this is doing it, helping you forward. And it's very interesting. Let's say, like, the goal is to go like 6 breaths a minute, which I can do because I've done a lot of respiratory fitness. The average person's not going to be able to breathe that little per minute without a lot of practice. And this will give you that practice. And let's say you can't do it and you start breathing, your breathing rate is going up. It's okay, because the musical tones will go with you and they'll bring you back down. So it's a computer. It can go where you go and then bring you back down. So it's a fascinating tool. Within 4 to 6 weeks, you should see a definite improvement in your blood pressure. I mean, I think it's a worthwhile thing. I have not done it myself. Again, it's not an issue that I have, but it's the only tool that I have found, non-pharmacologic, that I would even consider. And I have no financial, it's just something that's very interesting to do. And I believe in biofeedback, and also believe in the practice, the power of the breath. I use it all the time. What about food? Well, potassium-rich foods are your go-to. I don't normally give potassium supplementation. I don't think it's necessary, because potassium in our food is so ubiquitous. Tomato sauce, white potatoes, sweet potatoes, watermelon, veggies, fruits, yogurt. So it's so ubiquitous. But some people don't eat fruits and vegetables. I don't know. So you really need to keep that in mind. But potassium is your friend. It'll help lower blood pressure. And magnesium is the other one. Magnesium I recommend that for everybody. I take it myself. And the combination of magnesium and potassium, coupled with reduced sodium intake, is more effective and lower your blood pressure than just a single mineral by itself. So I kind of use it to potassium and magnesium. And they also, if you use these two in combination, it increases the effectiveness of drugs. So let's say you're taking drugs and they aren't working. Well, try the same drugs with these minerals, and it can make a difference, because oral magnesium actually acts like a natural calcium channel blocker. Those of you that are taking things like amlodipine, nifedipine, verapamil, those are calcium channel blockers, and they're vasodilators. But it's felt that magnesium itself is a mini dilator, arterial dilator, because it increases nitric oxide. You heard about nitric oxide. It helps the endothelium, that word again, and it keeps the arteries open, dilated, and your blood pressure will go lower. Supplements. I love CoQ10. Everybody should be on it over the age of 40, 200, 300 milligrams a day. Fish oil, there's no question. Fish oil should be a part of your regimen. Hawthorn berry can be useful. You need a larger dose of hawthorn berry, 500 milligrams, about 3 times a day, at least twice a day. And that can also be important in decreasing your blood pressure. I like earthing, and I was involved with a study on earthing, which is also listed in my book. And I worked with Dr. Steven Sinatra, my mentor, who unfortunately passed away in June of 22, and using earthing or being grounded as a way to lower blood pressure. It's also a natural blood thinner, and it has other effects. It's anti-inflammatory, helps with sleep. There's a myriad of benefits that I've talked about in the past, but it can have an effect on blood pressure. So it's something that's worthwhile. Again, it's non-pharmacologic and it's free. um, Stress reduction, we've mentioned a little bit of that with the respirate, but no matter what you do, working on breath control and relaxation and visualization can be very helpful in blood pressure. Then, of course, there are the drugs, angiotensin receptor blockers, and ACE inhibitors, beta blockers, calcium antagonists. I'm not going to talk about them unless you have specific questions because we all know the drugs are out there. But I will tell you that as an integrative cardiologist, and practicing functional medicine, I will use drugs when needed for blood pressure control. It's that important to me to have people's blood pressure control. So if I need drugs, I will use them. That's the one case because I don't want people walking around with high blood pressure long term, or it will affect the heart, the brain, the kidneys. So I want to avoid all that. So that's a lot of talking I did. I'm going to listen to these questions now. There's a lot of information, but I wanted to give you some cutting edge stuff. So thanks for listening. And let's go to the questions. Okay. Any supplements to lower blood pressure? Yes, I talked about the supplements. I always use, again, CoQ10, fish oil, and of course the electrolytes that I mentioned, magnesium and potassium in combination. So it's really important. Okay, another question. Levothyroxine for thyroid, taking losartan, which is an angiotensin receptor blocker, Jardiance, and 81 milligrams of aspirin in the morning, and phenofibrine. Wondering if I really need all these. And that's a big question. Do you need all those? Well, you got to come see me for that. There's no way with, you know, this is the era of polypharmacy. It's easy to just give you a drug and say, here, just take it. That's not the way I do things, but that's the way it's done, guys. I'm going to be honest with you. Medicine today, if the corporate world, it's like the corporate world. If you go to my hospital or in the hospitals, you have a heart attack, you're going to walk out with aspirin, beta blocker, Plavix, or similar kind of 8-time platelet drug, and I mean, you go to work and 80 milligrams of Lipitor. They give you huge doses. So they're not really individualizing treatment. See, this genetic testing is going to be a game changer, folks. It's going to tell us what we need to know, but you have to go to a doctor that's going to order it. You're not going to see it at your standard doctor's office. So I don't know whether you need all those drugs. You would have to come see me or see someone like me who can answer these questions for you. It seems like a lot, but again, I don't know your history, so I just have to be fair about that. Are some of these senior moment here, I need my glasses. Aren't some of these for the same issue? Are you funding big pharma? Yes, you are. But again, when it comes to drugs, I mean, I will use drugs for blood pressure if we can't get it under control. Now, I'll be honest with you: the average person out there doesn't comply with lifestyle. My patients tend to, because I have a special niche. I have a niche because I've created a practice that focuses on practicing prevention and lifestyle. But most people aren't interested. So look, I say go to the doctor. I don't want to be the pill pusher. It's not my thing. So you have to take whatever you need. But I like to think that there's a role for lifestyle first. But you're right. Some of them are using the same issue. Okay. Any other questions? There's got to be more questions. Did you guys like the information about the genetic testing? Isn't that exciting? Okay, we'll see. I've talked a lot today. I usually don't talk like more than 15 minutes, but I had a lot of information. Okay, another one. Thanks. What's your take on CMOS as a supplement with hyper? I don't know that one. This is, am I reading it right? CMOS? I don't know. I'm going to write that down and look it up. You don't mean seaweed. You mean sea moss, if I'm looking at this correctly. Okay, I don't know what that is as far as heart health. So you got me on that one. See, I'm honest. I don't know that particular one, but I will look it up. So what you can do is actually, there's comment section. If you mention that to me, and I'll get back with you. Write me, a text, a message. I'll get back with you. See, I've never heard of it, guy. I'm sorry, but I will look it up, and just please do it in the comment section so I won't forget. Okay. Anything else? We talked about a lot. So I know you guys have been patient. It's been over a half hour, but I just want to make sure I don't leave any questions undone. So if not, no, one more, wait another minute or so, and then we'll just sign off, I guess. As usual, I very grateful for you joining me tonight and all the times that we do YouTube Live. We will be doing one in 2 weeks. May is a very pivotal month for me because it's not just Blood Pressure Awareness Month, it's also Women's Health Month. And I like to look at women's health more than just a bunch of hormones, but look at the totality of the whole thing. And we'll talk about heart disease. And, men really are from Mars, women from Venus. And we'll go into that during Women's Heart Month, which will be 2 weeks from tonight. Um, Will my book be on audio? Yes, that is my goal before the end of the year. One of the holdups there is that I can't have someone do my voiceover. I really can't. It's not the first part of the book because the first part of the book is, as some of you know, is my story. I don't think anybody, how great a voice they may have, could really give my story the emotional impact it needs better than me, just because I lived it and I'm still living it. So, but my goal is to definitely do one that's in the next few months. So, before the end of the year, I will have an audiobook and I will be announcing it. So, thank you. I know that it's important. A lot of people don't want to read anymore. It's a different era, and or a lot of people spend a lot of time in their cars. So, you'll have that benefit of having an audiobook. So, yes, I will get back with you on that. So, those are the programs we have coming up. Thank you. And please, we need more people in these programs. I'm not getting as many people as I would like. So share this with your friends. I really would appreciate it. Give me a thumbs up every time you watch one of my videos. Every thumbs up is important. So I'm very grateful for the thumbs up, the reviews, and also please get my book. Again, last plug, beyourownmedicaladvocate.com. It's not just about my story. The biggest part of the book is how you can become your own medical advocate. And those of you that watch me regularly will see that we talk about this every time. Because after all, whose body is it? It's your body. And I always tell people, I'm your second opinion. Who's my first? You are. Nobody knows your body better than you. So a good doctor will listen to you. And that's the number one complaint that we have, is that most doctors don't listen to their patients. So get the book, share it with others, and please go to Amazon, write me a favorable review because we're trying to make this a game changer. Okay, guys, I think that's it. Thanks you and for your attention. I hope we see you in 2 weeks for Women's Health Month. Thank you again. Very grateful. Thanks so much, guys. Take care. Good night.